ratioed her to 1 to 3, or 3 to 1. Set the tidal volume same at 350. I upped my PEEP from what they had, because they had theirs extended out, and it was just such a weird mode. But looking at it and stuff, I decided to go with a PEEP of 14 is what I started with. By the time I got there, I was up to a PEEP of 18. My oxygen sats right there at the bedside in the hospital before I moved her over. We're sitting about 88, 89. I think by the time we got her up in the air and stuff, she dropped a little bit to about 86, 85, 86. So as soon as we got there, but we got her there in tidal, even though I inverse ratioed her, because you know with APRV you don't paralyze. Learn to assess your patient from head to toe, palpate them, you know, look for edema and stuff like that. Just really get your hands on there and do a good head to toe assessment. Listen to their abdomen, listen for heart rubs and murmurs. I cannot stress enough the patient assessment it takes to do what we do as a transport team, because there's just the two of us. There's us and our nurse, and that's it. We don't have anybody else, other nurses in the back of that truck or in that helicopter that can help us. So you've got to know your patient assessment, know the disease processes that your patient's on or have going on. If you're looking at the medications, look at them, learn them. If they're on vasopressors, learn why are they on them. What kind of drips are they on? Learn everything that you can learn to be able to take care of doing that patient. Get you a good foundation and a good base. And then if you want to do come transport, wear this fancy black onesie, you'll be able to do it. And that's really all I think that's all I have. Oh, we got references there. Mostly what Scott talked about. Any questions? All right. Good. Okay. Thank you guys. Thanks for coming out.
I'll be here till Tuesday. Try to be.
Try to what?
All right, we're going to take a quick break. 2:15, let's be back in here. We are streaming again in the overflow room. I apologize about that. The laptop that's running the webcam decided to take updates in the middle of the day. And it's not my laptop, so I didn't want to correct it. So anyway, we got that taken care of. 2:15 right here. All right, here's the drive. You doing all right?
I'm good. You?
Good. Thank you for being here.
My pleasure. Thanks for the invite.
Let you do all your stuff here.
So I just put it on the desktop.
Yeah, if you want to download it there or open it from the memory stick, that's most people are downloading them and then taking their stuff. And I will tell you the way that we have this set up, we have an overflow room, and the only way for them to hear the audio is for you to speak into this microphone. So what most people have been doing is wearing the lapel. I don't know, are you a lectern guy or do you like to walk around?
I tend to walk.
Okay, okay. So you could wear this and then just speak into this. Okay.
Hello, overflow room.
Test one. Test one, two. Test one. Test one. Oh, yes.
not sure why that hadn't been popping up to take the stick off.
Yeah, it's fine to take it off, I'm sure.
It hasn't corrupted anything yet. So you'll just carry this with you.
Turn it off until
Yeah, that's fine.
I'm ready. So
That's fine. Would you like some water or anything?
yeah, that'd be great.
Go grab it.
Yeah, I think. With the mouse, they can see it. They can see this?
Yes, they will.
But if I point with this, nobody can see it, right? Because I'll.
They can
point.
see it in here.
Right, but that's the problem. Is that
Yeah.
I'll point over here, then it won't be pointing over here.
Right, yeah.
So
The
I'll
over-
just use the mouse.
Yeah, that's probably your best bet.
Just don't forget that. You're gonna hold it close by.
Yeah, I know. We've been working on this because the only way we can grow the seminar is to have the overflow room. You know what I mean? So last year we Skyped to 4 different rooms, and we had laptops with cameras at the podium. So this year we bought the webcam, and we're just doing one room, and it's worked fairly well. But we've got to get the audio figured out. We've got to get the lapel mic to go
feed
into the webcam.
webcam.
Exactly. So maybe by 2020 we'll have this.
It'll be like daily safety check, and then someone
Yeah.
will put you on hold and play music. through the
Exactly.
whole-
Or wash dishes while they're doing it. 2 minutes.
Do I have to sign something?
No, I've got this to introduce you.
Is this the last talk?
Mm-hmm.
So I'm the only thing that stands between them and cocktails?
Between, yeah, or wise man. I'm going to go over to wise man. There you go. Okay, peeps. Get it? Peeps? Okay. Thank you for being here to the seminar. We appreciate your attendance. This is our 5th year. Maybe by 2020 we'll get the breakout room figured out where we won't have the computer going down and people having to carry around the microphone for like Richard Dawson had. So, but anyway, our last speaker of the day we have saved. How many people know who Richard Dawson? Okay, thank you. He had the. It was Gene Rayburn that had the one that was about that.
You're really going back.
I'm not even going to ask about that one, okay? But today we truly have saved the best for last. Dr. High is our Executive Vice President, Health System Affairs at Wake Forest Baptist Medical Center, a member of NCHA's Policy Development Committee, and has led Wake's expansion of clinical services to a nearly 40% increase over the last 3 years. Please join me in welcoming Dr. Kevin High.
Thanks, Dave, and thanks for the invite. It's great to be here with you. And I was talking a little bit just before Dave introduced me that I guess I should have changed my talk last night after Trump's executive order, right? So this is a fast-changing landscape, but I was asked to sort of give you some healthcare industry trends of this year. So I hope it will be of interest to you as respiratory therapists, but I think it may even be of most interest to you as people who buy healthcare. This is really all of us, right? It's not even if you're just a patient. If you are a consumer that buys insurance, it changes day to day, and the kinds of things that are going on in the healthcare industry change our responsibility versus what insurance is. And so there's a lot of differences from individual policies, individual plans, state to state, time to time. So I don't pretend to be all-knowing or all-seeing of the future here. Believe me, I have no idea any more than you do what's going to happen 6 months from now. But I'll try to give you some of the trends of where things are now and hopefully stimulate some discussion and conversation. And I'm a pretty low-key person, so if you want to interrupt me or say, what are you talking about? Please feel free to. And I'll try to make it as clear as I can. So we're going to try to hit 4 areas in healthcare industry trends, a little bit on payment reform, and then provider markets, purchaser behaviors, and what people go through and what drives their provider selection. So we'll start with payment reform, and I'll hit briefly on these 3 issues: value-based purchasing, bundled payments, and policy landscape. So who knows what value-based purchasing is? No idea, right? Well, what it means is that the health system goes at risk for the quality of the care they deliver, right? Right now, if you, I don't know, if you're a surgeon and you do a knee replacement and the insurance company pays you whether that knee replacement works 6 months from now or it doesn't, right? So that's a fee for service, widget-based thing, right? You went to Best Buy and you bought this and you paid for it. Well, value-based care is more, I went and I not only did I get a new knee, but it didn't get infected. And while I was there, I didn't get a DVT. And you got me out on time, and you know what? You got me out of the nursing home in record time and saved money for my insurance company. And so we'll give you some of that, right? So it's quality and cost of care that then drive the payment to the health system, not just that you did something or didn't. And there's a variety of ways that that happens, and it's shown from a spectrum here of just sort of meeting some criteria of you have an electronic medical record and you call your patients for yearly mammograms, that sort of stuff, all the way up to full risk, which means the health system takes all the risk. The insurance company just gives you money to care for this patient for the year, and you are fully at risk for how much it costs to take care of that patient, regardless of what happens to them. And then there's various steps along the way. And I'm going to focus on two of those, the bundled payments here, and then I want to say just a little bit about shared risk, because Wake Forest Baptist is one of the first healthcare systems to go to what's called a next generation ACO model. So we are getting closer and closer to full risk here. And this means there are certain Medicare patients that are attributed to Wake Forest Baptist, and we are on the hook for how much it costs to take care of those patients. And you might think, you know, knowing our patient population, which tends to be lower socioeconomic status, more comorbidities, very complicated patients that have multiple diseases and might cost more to care for, why would we want to go in that direction? Well, I think there's two major reasons. One is it's the right thing to do, right? To try to bring high value care to every segment of the population and give them high quality care, that is the right thing to do. And to design your systems to be able to do that, regardless of whether you can pay or not, or what kind of insurance you have, is actually good for everybody. It gives high quality care at the lowest cost for everybody. So that's one reason we're in this value-based care. The other is that we've been able to demonstrate that we are actually a pretty low-cost provider. Although you might look at us and say, it costs a fortune to go here or there, compared to what it actually costs other places when you capture the complexity of our patients. That's the key. If you capture the complexity of our patients and say, you know what, we're putting knees and hips in patients who have diabetes and heart failure and high blood pressure, and you compare that to people who put hips and knees in people who don't have any of those things, it's naturally going to cost more for us. And if you then compare apples to apples, us to other groups who put in the knees and hips in those high-risk patients, we do pretty well. We actually are a low-cost provider. So we're willing to go at risk for this, and that's why we're one of the first adopters of what's called a next-generation accountable care organization. All right, so the other thing is, has anybody heard of bundled payments? A couple of heads are shaking up and down. What most people think of for this is they'll pay you a certain amount for an episode of care, and it's for all of that care. So the biggest ones to date have been these comprehensive joint replacement ones right here, right? So you're going to get your knee replaced. They're going to pay the health system a certain amount, and it's going to cover the surgeon, it's going to cover the hospital, it's going to cover the nursing home if you need it, it's going to cover the physical therapist you need afterwards, it's going to cover the drugs you need specifically for that, the pain medicines, the anticoagulation, whatever you need during that time. It's all in one bundled price. And then it's up to the health system to figure out how to do it for that price, or if you can do it for less, the health system gets to keep the difference. That's pretty easy to think about for an elective event like I'm going to get my knee replaced 2 months from now. Well, bundled payments are about to change to episode payment models, right? Where they're going to pay health systems for acute heart attacks and episodes of pneumonia as a single cost, right? So if you go here to the bundled expansion of the future, which means next year, next calendar year, the top two are simple pneumonia and respiratory infections, and COPD, bronchitis, and asthma exacerbations. So you see those all the time in respiratory therapy. And whether someone goes home on oxygen, it's a big difference in cost. If somebody gets a readmission afterwards because they weren't ready to go home, or their home environment, it has all kinds of allergens in it and they relapse when they go back, that episode of care will only be paid a certain amount regardless of how much it actually costs to take care of that. So I guarantee you, whatever health system you work for, they are going to be looking to respiratory therapy in the not too distant future to try to lower the cost of care for COPD and COPD exacerbations and asthma exacerbations. So this bundled payment of care is going to be a way you are going to be pulled into this very shortly. Uh-oh, software changes are required. Is it going to like go off or something? Now this slide, as of last night, is out of date. So, you know, the Accountable Care Act, or what many people refer to as Obamacare, right, was under tremendous fire for the last 6 months. And, you know, the two options were immediate wholesale repeal if Congress could have passed something the president signed. That never happened. And so what we started last night was piecemeal change, right? An executive order that says, okay, now, insurance companies, you're allowed to sell your plan across state lines. And you're allowed to vary what you put in those plans. You don't have to cover exactly what the other programs in the exchange program do. So what does that mean? Well, we're not sure yet, but it probably means higher premiums for people with diseases, lower premiums for young people who aren't buying insurance now to try to get them in the exchanges. And it will mean that you don't have to have an insurance license in a given state to go in and start selling to that state. So there may be a cross-state line competition between maybe Blue Cross Blue Shield of North Carolina will be competed against by Blue Cross Blue Shield of Virginia. All right? That doesn't happen now. It can't, because they are state specific. So we'll get to a little bit later in the talk what that might mean for premiums and the cost of care. Okay, so what's happening in the provider market, in finances, some volumes, a little bit on imaging, and then some primary care options in telehealth. So for about 6 or 7 years, healthcare costs had dropped a little bit and remained quite stable, going up 3 to 4% per year. Now, inflation was like 1 to 1.5% per year over this time. So it was still higher inflation for healthcare than it was for the general public, but you can think about what happened to gas prices 2 years ago, right? We were paying nearly $4 a gallon, and now we pay $2 something. Well, that's in the general inflation, so that pulled down general inflation dramatically. In healthcare, what happened? Drug costs went up and up and up. And almost none of this inflation is hospital or professional fees. It's almost all drug costs. And I'll show you that in a few slides. Here's hospital spending and what's gone on there over the last several years. And you can see it's only gone up 1 to 2%, or in 2015 it actually went down. And in fact, part of this is these at-risk payments. Many of the hospitals that took those at-risk payments didn't do very well, and they actually lost money on those programs. Outpatient continues to go up. The top is outpatient growth since 2006, and the bottom part, the darker line, is inpatient growth since 2006. And you can see that inpatient growth has gone, or inpatient business has actually contracted by 17%, while outpatient volumes have gone up by 33%. And what's likely to happen in the next few years is shown on the right side of this slide. Inpatient cardiac services are likely to fall by 13% in just a few years, and vascular services as well. Now, outpatient services go up for all four listed: cardiac, vascular, orthopedics, and neurosurgery. They also go up on the inpatient side a little bit for orthopedics and a lot for neurosurgery, and that has mostly to do with the aging of the population. That's why that whole pie is getting bigger, and so it's going up on both inpatient and outpatient. But cardiac services are so outpatient now and so easy to do in an in and out fashion. You know, you go in, even with a heart attack, you get a stent and you're gone in a day. If you didn't have a heart attack, you don't even stay in the hospital. You just had chest pain when you walked, you never get in the hospital. You get a catheterization as an outpatient. If you need something else done, you get that as an outpatient. If you need a pacemaker or something, you never get that done as an inpatient anymore. It's all outpatient work. And orthopedics is rapidly heading that way. You get your hip or your knee replaced now, you stay one night in the hospital, tops. And the government is pushing very strongly for Medicare to have what's called a 23-hour stay, right? Where you come in and you have 23 hours to get them out of the hospital, which means you get an observation rate, not an inpatient rate for that stay. So it saves the government a ton of money. What it really does is make the family take care of you in that time, right? Because now your husband or your wife or your child or your parent is taking care of you at home, trying to time your pain meds, trying to get you out of bed, maybe has a bedside commode. If not, you got to get to the bathroom on the same floor, can't go up and down the stairs. It really increases the burdens on the families. It probably is better for patients to not be in the hospital. I'm not arguing that. But it is a life-changing event for not just the patient, but their family for a time, if we do more and more of these things as outpatients. Imaging is another place that has gone down dramatically over the last several years. And it's because Medicare has put great restrictions on what you're allowed to image and how often. And we were just talking about a family member here who could have used a follow-up imaging service, but insurance denied it. And imaging services are quite expensive, so when people have to pay for it themselves, they choose not to get it very often. The other thing that's happened that's driven a lot of this cost to outpatient is look at all these choices you have now. Right? You used to have a primary care office and you had an urgent care center and an emergency department as your outpatient choices. Well, now you have virtual visits, you have email visits, you have mobile apps, you have remote monitoring even for things like bad heart rhythms, fatal heart rhythms, right? You have somebody who wears a monitor at home and then puts the monitor up against their cell phone and phones it in to somewhere in Detroit or something like that, right? All those kinds of changes have really moved healthcare into the outpatient setting and away from the hospital. And these are just this is just one example. The retail clinics, so Minute Clinics or Walgreens or Walmart or Target, and how many clinics have grown over the last several years to where there's now 2,500 estimated total retail clinics in the U.S. as of 2016. And telehealth. So this line looks really impressive, right? 600% growth over this 10-year period of time. But look at the total amount of Medicare expenditure in the telehealth setting. Even with that, it's still only 0.0023% of all Medicare spending. Why is that? First of all, the Medicare population doesn't like telehealth, right? They just don't like it. So they're not the big users of telehealth. The millennials, they love telehealth. They don't want to have to go in to see anybody. They want an answer on their phone, and they want it while they're on their coffee break, which is most of the day. No, I'm kidding. Maybe if you work at Google. Have you seen that commercial about how now I can get my work done on the train before I get to work, and all day at work they're just playing, and you know. But But I really do think there's a generational issue here. So Medicare data may not be the best choice. But we did this at Baptist for a time. We had what was called teledoc for our own employees. It was considerably less expensive than going for a visit intentionally to try to incent that behavior. And we, in 14,000 employees, were getting like 20 calls a month. That's it. People are not quite ready to accept telehealth for most things. Often because what they tell you is, well, you need to be seen, right? Well, that's not very helpful. It's good for what some may refer to as the worried well, right? Somebody who has the same complaint that you already evaluated in the office, and you have to just reassure them that it's not anything new or different. Well, that's not very common. It's probably good for saying in the middle of the night, a worried parent that first-time child, you know, hadn't dealt with an earache before, that sort of thing. Those of us who have 3 kids, you know, by the 3rd one, you're like, they're screaming, and you get her. No, I'm not getting up. You get her, right? Whereas the first one, you're like, what's going on, right? So there are times when telehealth fits your life, but at least at the present time, it's not a major way healthcare is delivered. Now, we are using telehealth and going to expand telehealth a lot to keep patients in their local hospital rather than at Wake Forest Baptist. So we have Wilkes Medical Center, Lexington Medical Center, Davie Medical Center in our network, and we transfer about 100 patients a week from each of those facilities to North Carolina Baptist in Winston-Salem. About half the time, that's for an opinion from a specialist that's not available there, rather than for a procedure we only do at North Carolina Baptist. Well, I'm an infectious disease doc. I can sit with a hospitalist in Wilkes with an iPad and do a consult on that patient and keep them there if they don't need something done down at North Carolina Baptist. So I think that's the way teleconsultation is going to move, and telehealth will be much more effective in an inpatient setting where you have professional-to-professional interaction with the patient there. The patient straight to the professional who's not their regular doctor and who can't then perform if you need a test of some kind, or you need your throat swab for a strep test, that sort of thing, is going to be difficult to do on a teleconsultation to patient satisfaction by and large for a little while, I think. Okay, how about purchaser behavior? What are we buying? How are we changing what insurance coverage we have? Well, this is the estimate of U.S. adult uninsured patients, and you can see that major coverage expansion for the Accountable Care Act occurred in January 1, 2014, and there was a substantial drop in the number of uninsured patients over the last 2 years. There is no denying that the Accountable Care Act insured more patients. Almost all of that is from expanded Medicaid in specific states. In states where we did not expand Medicaid, like North Carolina, there was not a big change in the number of uninsured. So that sounds really good, right? But there are some unintended consequences of this that I'll show you that have not necessarily been on the positive side. But as someone who takes care of lots of patients, including Medicaid and self-pay patients, it's pretty hard for me to argue that people shouldn't have access to care. And this was a way to at least make a dent in that. And you can see how hard it has been to repeal the ACA, because now all the patients that didn't have insurance up here had some insurance, and you were going to make angry all of those voters, and you couldn't get enough votes in Congress to essentially get rid of health care for those patients. And that changed the dynamic. So I think it really did accomplish one of its goals, which was to insure more patients. Now, these exchanges are very unstable because it cost a lot more to take care of the patients than they thought it would. A bunch of the low-risk people are still uninsured because they're essentially playing the odds. I'm 24, I don't have any major illnesses, I'm not going to get insurance, right? Because I can't afford the monthly payments. And that has made these programs very, very unstable. You know, in some states, only one insurer. 5 different states in the country have one insurer that provides an ACA-based insurance policy. In many states and counties within those states, there's only one insurer, including in North Carolina. Nearly half of the counties have one insurance plan in them. So it is a very limited option for folks. The other thing is that there are more insured people, but there is also more underinsurance. Okay? So while more people have insurance, more and more people are getting what we would often consider inadequate insurance. So you can see here the kinds of policies you can get are platinum at the bottom, bronze at the top, and gold and silver in the middle. And you can see from 2014 in the darker blue to 2016 in the lightest blue, what's happened to the average deductible for these different plans. It's gone up in all of them. But if you have the platinum plan, your deductible went from $233 to $347. Not too bad, right? But if you're in the bronze, look at these deductibles. These deductibles are from $5,000 to almost $6,000 a year deductible. And that's if you were in the bronze and stayed in the bronze. If you said, man, I can't afford the gold, I've had the gold, but I just can't afford it anymore, you go from deductibles of about $1,100 to $5,000 and $6,000 a year. That resets every year. I mean, that's essentially like not having insurance for most preventive care, right? That's why I say it's increased the number of underinsured. Because if you got to pay $5,000 on top of your insurance premium, you're never going to hit that deductible unless you get sick, right? And so most people just avoid whatever they would have had to have paid by a deductible. They just don't go. And despite these high deductibles, these plans are not cheap, right? So here is Blue Cross Blue Shield of North Carolina's individual ACA qualified health plan for a 25-year-old, a 40-year-old, or a 60-year-old. And even the bronze plan, the one with the $5,000 and $6,000 deductible, if you're 25, is about $200 a month. But if you're 60, it's $500 to $600 a month with a $5,000 deductible. So you're paying $6,000 a year in insurance, and you have $6,000 worth of liability. That's $12 grand a year before your insurance starts paying anything, right, for you. That's why people are just saying, I'm not going, I'm not getting it, I'm not doing it. We cannot afford to keep going in this direction. We have got to lower the cost of health care. We cannot afford it. None of us can afford it. And we're only starting to see this now because we're getting stuck with the bill instead of our insurance company or our employer being the ones that are paying all of the bills, right? The employers can't afford it anymore, so they're shifting to the bronze and silver plans, and that shifts it to you, right? And then you have the deductibles. We have separated the cost of health care, by and large, from the consumer of health care. I mean, if I asked you how much it cost to be hospitalized for 7 days with a COPD exacerbation, you would have no idea, right? Even though you work with COPD patients all the time, because you don't get a bill when you leave the hospital. You get it months later in an unreadable format with what your insurance paid and what you're liable for, and did you meet your deductible or not. It's impossible to know. So we have completely disconnected the economics of paying for healthcare from the consumption of healthcare. And that's one way that bundled payments will start to bring that into clearer focus again. So what I had showed you was Obamacare or ACA exchange plan costs. You can see that employers are turning to much higher deductible plans as well. The percentage of covered workers with an annual deductible of $2,000 or more has climbed in small firms to nearly 40%, and even in firms with 200 or more is up to over 10%. So higher deductible plans are being picked by employers as well. Okay, but, right, my patients love me. They'll never leave me, right? No matter what the deductible is. Well, wrong, right? There are lots of reasons why people pick a doctor. And I'll try to get to some of those in these next few slides. This is sort of the way it used to be, right? You had a primary care provider. There were all sorts of ways you ended up moving to that primary care provider. But as you needed more and more medical care and moved along this spectrum horizontally to a medical specialist and to a proceduralist and requiring hospitalization, a lot of what you would do is you'd say, well, doc, who's the best person to do this, right? And so top-notch specialty capabilities and technology, superior access, you know, a surgeon who could see you the next day was more likely at your business than a surgeon who couldn't see you for a month, unless that surgeon was, boy, he's worth the wait out there, and people would say, you know, you should wait for that person. And, you know, there was this feeling that if we did high enough quality care, people would wait for us, right? Well, the emerging thing that's happening in this is it's really, do you have this continuum of care readily available for everybody? Do you provide the highest value care, not just the best, but the best at low cost? Best outcomes at lower cost. And then superior patient access and experience. Access is everything, especially with the younger generation, right? If you can't get in later today to see your doc, why would you go? Go to the Minute Clinic, right? There are plenty of other acute options that are easier to get to. So these are the top 10 reasons why people say they want to go to that primary care clinic. I just highlighted the top 5. Number 1 is I can walk in without an appointment and I'm guaranteed to be seen in 30 minutes. That's number 1. Number 2 is if I need labs or x-rays, I can get them done at the same location. So that is one advantage docs' offices tend to have, especially in a multi-specialty office building, that a Minute Clinic or Walmart doesn't yet. The provider's in-network for my insurer. The visit will be free. Not I can afford the copay. The visit will be free, right? The feeling is primary care ought to be free. And then the clinic's open 24 hours a day, 7 days a week. That's sort of the same way as saying I can walk in without an appointment, right? Extended hours, weekends, all of that. That's why people pick primary care. It's access, 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 and I want it to be free. Okay? And people don't stay loyal to their primary care provider if those things aren't available, right? Here's a question that was asked of patients. If your primary care moved to another clinic or practice, how likely are you to follow him to that practice? 9%. How likely are you to stay if your primary care physician, or how likely are you to stay over the next 12 months with your primary care physician? Only about half. So that means only about half of us are even enamored enough with our primary care physician to stay with them for the next year. How likely are you to recommend to your friends? Only about a third. So we are not that thrilled with the primary care we're getting now. When it comes to how people pick a doctor, friends and relatives recommending them is far and away the most important. Much more important than things like board certification, right? It really is who recommends them. And that's word of mouth is what most frequently drives a consumer choice for a doctor. Now, what if you're shopping for surgery? If you have an elective procedure, what's the most important thing? It's how good the quality of care is, right? Not even close. Price is the most important thing, more important than every other factor on this slide, right? Cost of surgery drove the relative importance in 53% of the time. Travel time to the hospital was the next biggest. So they want it close and they want it cheap. A referrer's recommendation, so your primary care doc says you should really go to this person. That was only 10% of the choice. Which hospital they're affiliated with, only 7% of the choice. Quality of the surgeon, 4.9. They want it cheap. Quality is not going to carry the day. They want it cheap. Quality is important, right? They would love to say, yes, I want somebody who gets a good outcome, but quality is assumed. The assumption by the public is everybody who can put a knee in me is pretty much going to do a good job of it. Right? Now, we're in healthcare. We know that there's some people we'd rather go to and some people that we'd rather not to go to, right? But that is not the general public's perception. Quality is assumed. So if you really want to tout your quality, you're going to have to be really far above the competition to make people come to you for that. They're much more likely to come to you for a low price. And higher deductibles are what's driving this too, right? Because the patient has to bear more of the cost. So in households without enough liquid assets to pay their deductible, there's now, that's 35% of the higher deductible range policyholders. 1 out of every 3 don't have the money to pay their deductible. So they're going to shop very carefully, and they're going to get the low price. I'm going to skip that in the interest of time. So what are the essential conclusions out of this sort of quick overview of the state of healthcare these days? I think one is that value-based care is continuing to increase, but you have to be ready end-to-end to address bundles, especially things like a COPD exacerbation. How are you going to do both the inpatient and outpatient and follow-up care in a seamless fashion for a set price and give high quality and low cost? The ACA has reduced the number of uninsured, but it has not penetrated the market as much as it was thought to, and it may have actually increased the underinsured due to very high deductibles, both for exchange products and for employer-based insurance. Other conclusions: primary care provider loyalty is very limited and based almost entirely on convenience and price. People go where their friends recommend it. That may be the most important reason to have high patient satisfaction scores, right? Is if you want people to keep seeking you as a provider of care, you better provide a good experience for people when they're there and have high patient satisfaction scores. Specialty care is not driven by the quality of the doctor, but by the cost of that care. And it will be continuing to evolve in that way. So what does this mean for respiratory therapy? I tried to think of a few things on my own, but I'm sure you could add a dozen to this. There is increasingly shifting care to the outpatient setting, and I think there's going to be the need for respiratory therapy in the community much more than there has been in the past. Bundled care will likely be part of your world very soon, if it's not already. Value-based contracts likely to include respiratory care, evaluation, and therapy like COPD or asthma. And the big one is going to be oxygen and how much we use oxygen, because more recent data is really arguing against the use of oxygen long-term in outpatient settings. In the vast majority of people, it's really hard to show that it changes mortality. And then finally, all of you are consumers. So all of you will be affected by this for insurance premiums, deductibles, benefits plans, etc. in the years to come. And none of us has any clue where this is going, either locally or nationally, right? Because it has changed dramatically with the whim of this last election, and could just as easily change back with another election or with another economic downturn, right? I mean, that's the other thing that really worries me. We have had this happen in a time when the economy has actually been very good, right? Unemployment is now down below 5%. So, and it's hard to get good workers in a lot of places. And so companies have had to keep pretty good benefits to keep workers there. When the economy goes down next time, the first thing companies are going to do is cut benefits. And they're going to do it widely. And those ones that have gold and silver are going to go all to bronze. And it's going to be harder and harder. So I'm actually as worried what will happen with an economic downturn as I am with an election. That being said, there is no better job in the world, in my opinion, than being in healthcare. I don't come here for the money. I don't come here for, the U.S. News and World Report rankings. I come here because I can sit across from my patients on Friday afternoon in my clinic and hear their story and help them. And hopefully that will continue to be what motivates us in this. And high quality care, doing the right thing for your patients is always the right economic model. And I hope that'll continue to be our goal. So, thanks very much. Thank you. Thank you. I'm happy to answer a few questions if you have. This is the closest thing I can come to an oxygen tank. In my, that's my son who lives in Hawaii.
Ask, that's your son?
Yeah. He's the much better looking one.
Where are you?
That's off of Waikiki Beach. He lives in Hawaii, so.
Oh,
yeah.
the poor boy.
I know.
Bless his heart.
He moved there 9 years ago, and for some reason doesn't want to come back.
Yeah, that was 2011.
Yeah.
6 years ago.
So, yeah. Yeah, so, right. So the question here was if you are admitted for COPD exacerbation and you have a UTI or develop a UTI, that you don't actually get paid for that UTI. It comes off of the charge. In the hospital setting, we have gotten paid for many years in what's called a DRG-based payment, which is diagnosis-related group, and it means you get paid for an episode of care, right? Now, the main DRG drives that. So if the main reason you're there is a COPD exacerbation, it is a set amount. Now, that being said, there are adjusted payments based on some things that happen in the hospital. Sometimes you just write them off, and other times you do get additional payment, which is one of the reasons that, the clinical documentation people call us and say, they're really malnourished. You really should put that in your note, because that adjusts the DRG payment, right? So there are a number of ways you can get adjusted, but you're right. If they happen to have a urinary tract infection and you're giving them antibiotics for their COPD and it treats their urinary tract infection as well, you don't get anything extra for that. Yeah. Any other questions? Well, thanks again for the invite. I really appreciate it, and nice to be with you.
Okay, people.
Hang on, we have a few notes to tell them.
I got a few announcements here. Gonna draw for prizes. Don't go anywhere. Thank you, Dr. High. Appreciate it.
Okay, after you've filled out your evaluation forms, be sure to drop them off at the tables out in the atrium in order to collect your CEUs. The golf carts will be running only until 3:45 this afternoon. They're being picked up at 4, so if you don't catch one by 3:45, you're going to be walking back to the parking lot. So, all right, up for grabs. We have,
Seeing Chick-fil-A here.
and we got some Starbucks too. Let me put all the tickets back in here. All right, we're going to do a Starbucks first.
Is anybody over there? Do I need to hold this?
All right, ticket number 453645.
I heard moaning.
Everybody's moaning in here. Everybody moaning in the other room. It was 453645. All right, no one's yelled from the other room, so we'll keep going. 453614.
Should have tickets in here.
Oh, huh? 453614. Right there. We have a winner.
Heather, come on down.
Cheer for Heather. Okay, this is for a cup of candy. 453664. All right, we got it put on the back row. All right, for a $10 Chick-fil-A gift card. Four, 5, 3, 6, 3, 2. Oh, Donegal. All right. Cup of candy and one more gift card to go. This is for the cup of candy. 453707. Who said me?
Masha.
Oh. Throw it at her. All right, and for the last $10 Starbucks gift card. Four, 5, 3, 6, 4, 1. And we have a winner right there. All right, I'd like to thank everybody for coming, and we'll see y'all again next year. Thank you.
Thank you for being here. Wise Man Brewery time. Yeah, it's wonderful. First round's on Jim Pittman, Wise Man Brewery. Well, dim the lights. I should leave that there. I'm gonna stick this because we did.
That was a great job, thank you.
No, thank you, Beverly.
My pleasure.
Thank you for the job you do every day.
She's ready to work for Chick-fil-A. My pleasure.
It's my pleasure.
No, I'm just excited. I heard the pump went up today.
Yeah. Now, what about all this stuff?
I don't know.
Well, this is Mindy's, right?
Anna's in charge of Mindy stuff, I think. Mindy left.
Mindy
But
left?
I heard. I don't know that for sure.
Mindy left.
Mindy left.
Did she get virtual?
Mindy never leaves.
Whenever that starts. Anna and Ellen were manning stuff out here.
Huh. I just don't know what's ours and what's theirs.
And it's little.
I don't know. And does the camera come? Yeah. How does it come off of there? Ooh, boy. I'll shut down the laptop.